The topic of this lecture is indications and management of implantable electronic cardiac devices in ICU patients. My name is Melanie M. I am an instructor of medicine at Harvard Medical School and a member of the Brigham and Women's Hospital Cardiac Arrhythmia Service. These are my disclosures. There are a number of different implantable cardiac devices that exist. There are pacemakers that can either be single chamber or dual chamber with leads in both the right atrium and right ventricle. There are implantable cardiac defibrillators. Again, can either be single chamber or dual chamber. You'll see that the generator is much larger with a high voltage lead that has defibrillation coils that can be present only in the right ventricle or in the case of dual coil high voltage leads in both the right ventricle and ideally at the SVC RA junction. And there's cardiac resynchronization therapy that can include pacing alone or in conjunction with defibrillation therapy. And in this instance, there is a lead in a branch off the coronary sinus to pace the left ventricle. Traditional or conventional device systems, as shown in the prior three images, consist of a generator or can with transvenous leads. However, newer technologies include the subcutaneous ICD with a can in the left mid to anterior axillary line and a subcutaneous high voltage lead tunneled under the skin in the left parasternal region. And the leadless pacemaker or transcatheter pacing system, which is a self-contained unit consisting of the generator and the electrode implanted in the right ventricle with no can or generator under the skin and no transvenous leads passing back all the way through the vasculature. So a pacemaker creates an electrical circuit using the body tissue as part of the circuit. And it is able to deliver electrical impulses as well as sense cardiac depolarization. And the pulses can be delivered in a number of ways depending upon how the device is programmed. So as mentioned previously, conventional devices consist of the pulse generator, which houses a battery and circuitry, and leads or insulated wires that are connected to the generator through a connector block or header. Leads can be of several different varieties. They can be passive fixation leads that have these plastic tines that become lodged within the trabeculae. Or they can have an active fixation mechanism where there's a helix or screw that is extended into the endocardial tissue, thought to provide slightly more stability and allow for positioning anywhere within the chamber. And then there are epicardial leads that are applied directly to the surface of the heart. They can be an epicardial stab-in lead, a myocardial screw-in lead, or a suture lead, and they are applied either via sternotomy or thoracoscopically. This is a gross pathologic specimen that shows how the leads can become quite attached to the body over time, not only at their insertion point or tip, but also in points of contact along the muscle or vasculature in its course back to the generator. So I want to switch gears now and focus a little bit on pacing indication, types of pacemakers, and interpreting ECGs with devices. I've already mentioned the different chambers that the leads can be placed in. And this has resulted in a coding system or naming system to describe the type of pacing that is being utilized. It can get quite complicated, but conventionally, really we focus on primarily the first three or four positions in describing the pacing mode. So the first position describes the chamber that's being paced and can be none, the atrium, the ventricle, or both. The second position describes the chamber sensed and has the same sort of potential options, including no chamber is sensed, the atrium alone is sensed, the ventricle alone is sensed, or both the atrium and ventricle are sensed. And the third position refers to the response to sensing, with O being there's no response to a sensed event, T being a triggered response to a sensed event, I being an inhibited response to a sensed event, and D being both triggering an inhibition in response to sensed events. The fourth position, really the one that I think probably we encounter most commonly, is when you see an R for rate modulation. So the different pacing modes can result in a number of different ECG appearances, and it's determined not only by the type of pacemaker, but by how the device is actually programmed. So one could have a dual chamber pacemaker programmed DDD and actually see no evidence of pacing if the intrinsic conduction is such that there is atrial activation and ventricular activation that are above the programmed lower rates of the device. So this is an A-sensed V-sensed event. You could also see that you have an A-sensed event followed by a ventricularly paced event, or alternatively an atrial paced event followed by intrinsic conduction to the ventricle and a V-sensed event, or no evidence of intrinsic conduction based upon the program parameters of the device with an atrial paced and ventricular paced event. So a pacemaker is really basically a clock. If we think about VVI pacing, so we are pacing the ventricle, sensing the ventricle, and our response to a sensed event is inhibition. It's really a clock that has a timer. So if we theoretically say that we're going to set the rate to 60 beats per minute, that means that the clock will deliver an impulse every second unless there is an intrinsic event that occurs before the timer expires. So it's really a pacemaker. The pacemaker is really a clock that's able to reset. So if this represents the 1 second clock, but there is a sensed event that occurs before that clock expires, it inhibits the output. It does not deliver an electrical impulse, and the clock resets, and the 1 second starts over from that sensed event until it times out. And if it times out and it does not sense an event, then it's going to deliver an electrical impulse. So a DDD pacemaker, or a dual chamber pacemaker that's programmed DDT, is really two clocks that are able to reset. There is a clock for the AV interval, which you can think of as like a PR interval clock, and then there's the lower rate limit clock, or the rate clock, from atrial event to atrial event. So the most commonly encountered modes of pacing in the United States would be AAI, VVI, and DDD. AAI and VVI are really the same mode of pacing, just in different chambers. There is a clock that is programmed to a certain time interval that can reset if a sensed event occurs. The DDD pacemaker, as mentioned, is two clocks. There's an AV interval clock and a lower rate clock, both of which can reset. And you can see the number of different sort of pacing, EKG configurations that can occur with these modes of pacing. Well, how does a pacemaker sense? How does it know that an event actually occurred? Well, there is an item that's programmable called sensitivity. And basically what it does is it creates a fence. And the pacemaker will only see things above the program height of the fence. So if the program sensitivity is set to a value of 2 millivolts, it's only going to see events above that are larger than 2 millivolts and label them as sensed events. If we actually lower the fence or increase the sensitivity of the device, you see that we start to see other events such as the P wave and the T wave, which we might not want to be interpreted as an actual sensed event. So sensitivity is how the device can tell whether or not a sensed event has occurred and then determines what to do in response to that sensed event. Implantable defibrillators are tachyarrhythmia devices that consist, again, of a generator, also called a can or a box, and leads. It can provide pacing as well, and it's used to treat tachyarrhythmias either with pacing therapy or with energy delivered as a shock. The first human defibrillation occurred in 1947. But the first implantable type of defibrillator wasn't developed until 1970, and it wasn't until 1980 that the first human implant occurred at Johns Hopkins. It reached market in 1985, required thoracotomy to apply epicardial leads, and it was a large can that had to be placed in the abdomen. In 1991, transvenous defibrillation leads were developed. Again, the can was quite large and had to be placed in the abdomen, and it really wasn't until 1995 that fully transvenous systems with pectoral devices became commercially available. And you can see how with advancing technology for both circuitry and battery, that the size of these generators has changed over time. So how is high voltage created? Well, the battery really provides the energy for both low voltage and the energy for shocks. So a transformer multiplies the voltage and a capacitor stores the energy for later use so that a high voltage shock can be delivered on demand. The vector of defibrillation is really occurs between the defibrillation coil and either the summation of the SVC coil and can, or the ICD can alone if the SVC coil is not present, if it's a single chamber high voltage lead. You can see that this is obviously needs to be thought about in 3 dimensions, and that the can sits quite anterior, and that the shock vector is actually directed rather anteriorly, while a large part of the left ventricle sits in the posterior chest and is not captured by the defibrillation vector. But how does the device know what to shock? Well, the high voltage lead has a sensing electrode, just like a pacing lead does, and can sense and record electrical impulses at the tip, which is called the near field electrogram, as well as a far field electrogram between the tip and the can itself. So the device is constantly watching for electrical activity, and it will sense those events that are above the program sensitivity and record an intracardiac electrogram for those sensed events. It primarily determines whether or not an arrhythmia is occurring based on rate, and the rate is something that's programmed. That being said, there are a number of discriminators that are programmable to try and reduce inappropriate shocks for rhythms such as sinus tachycardia or atrial fibrillation, but they're not entirely foolproof. So the devices can look at electrogram morphology and RR stability in terms of trying to determine whether a rhythm is supraventricular or ventricular in origin. If the device has an atrial lead, that's also similarly useful in determining whether the arrhythmia is one that requires treatment or not. That being said, the device always errs on the side of caution and does not want to potentially miss a ventricular arrhythmia, so inappropriate shocks do occur, sometimes at a rate of 15 to 20%. Subcutaneous ICD is a more recent technology that became available within the last 5 to 6 years. It is inherently different in that it requires no venous access and was designed to hopefully reduce complications. It does not require any fluoroscopy for implantation and is appropriate for a broad range of body types. It really is an option for a majority of primary and secondary prevention ICD candidates. It cannot deliver pacing therapy at the present time, so therefore is not necessarily an option for patients who have a permanent pacing indication or need for for pacing to treat tachyarrhythmias. And it is an alternative to transvenous ICD replacement due to lead malfunction or infection. Shown here again, the can is rather large at the present time, sits in the left mid to anterior axillary line, and has an electrode that's tunneled subcutaneously over to the sternum and along the left, most classically the left parasternal border. There is overwhelming data about the benefit of ICD therapy for the prevention of sudden cardiac death. And this has led to ICD coverage decisions by CMS, which clearly support secondary prevention for those patients with prior cardiac arrest not due to a transient or reversible cause. For patients with familial or inherited conditions that are associated with a high risk of sudden death, as well as for those patients with either ischemic or non-ischemic cardiomyopathies and reduced left ventricular function. Patients may not have been revascularized or sustained an MI within a certain time period prior to implantation, and they also must have a life expectancy that exceeds 1 year for consideration of defibrillator therapy. Cardiac resynchronization therapy, CRT, or BiV therapy. Well, the mechanical efficiency of the heart can be disrupted when the relationships between atrial and ventricular contraction are disrupted, or when there is a disruption between the right ventricle and left ventricular contraction, which is so-called interventricular dysynchrony, as well as when the abnormal activation of the left ventricle is altered, so-called intraventricular dysynchrony. And so in the normal heart, this is a tagged RBC scan of a normal heart, and you can see that contraction is highly organized with contraction extending from the base to the apex, and there is a bit of a twisting or corkscrew motion, although not necessarily best displayed, and septal to lateral inactivation. When someone has a cardiomyopathy, their heart remodels, and as a result of the remodeling, their contraction is disrupted. And so if we just looked at this left ventricle, we can see now that that blue pattern of activation is really not proceeding in an organized fashion at all. And the goal with CRT is to try to restore some order or some synchronization of contraction. Again, evidence abounds to support cardiac resynchronization therapy and its ability to reverse remodel hearts to decrease left ventricular end systolic volume and end diastolic diameter, to improve left ventricular ejection fractions, to decrease mitral regurgitation. They also have been demonstrated to reduce heart failure hospitalizations, improve symptoms in 6-minute walk tests, and reduce all-cause mortality with long-term follow-up. In fact, the benefits of CRT, however, are most pronounced in patients with QRS durations that are greater than 150 milliseconds, or those with paced QRS durations greater than 200 milliseconds, and mostly in those patients with true left bundle branch morphology. An interesting point that many people may not focus on is that the benefit, the mortality benefit of CRT actually exceeds that of defibrillator therapy in a number of studies, demonstrated here as the event rate and all-cause mortality, and here as event-free survival, that CRT has a benefit above and beyond defibrillator therapy. So how do we achieve cardiac resynchronization? Well, the goal is really to pace the right and left ventricles and be able to optimize timing. Leads can be placed directly on the ventricle itself, which would require either sternotomy or thoracotomy or thoracoscopy to place the leads directly on the left ventricle, or transvenously, which means that we would actually access the coronary sinus and place a lead into a branch of the coronary sinus in order to pre-excite the basal lateral LV wall. This is an occlusive venogram of the coronary sinus that shows you a posterior branch, posterolateral branch, anterolateral branch off the coronary sinus, retrograde filling of the middle cardiac vein, and identifying a very nice target for a posterolateral, for placement of a left ventricular lead in the posterolateral branch. And you can see that ultimately that's where this coronary sinus lead was placed. It results in a pretty dramatic transformation of the patient's ECG. So here we see baseline sinus rhythm with a wide left bundle branch block. Following initiation of resynchronization therapy, we see a narrow QRS with pacing and with pre-excitation of the lateral left ventricle, as evidenced by the prominent R wave in V1 and the QS waves in 1 and AVL. So CRT is indicated for patients who have left bundle branch block, technically greater than 120 milliseconds, understanding that those with greater than 150 milliseconds derive the most benefit. Primarily, again, with left bundle, although non-left bundle patterns can be considered as well. And for those who also have cardiomyopathy and are anticipated to have frequent ventricular pacing, classically defined as greater than 40%. Patients with class 4 or end-stage heart failure really are not deemed to be candidates for resynchronization or defibrillator therapy. More recent advances in cardiac devices include the leadless pacemaker, also called the transcatheter pacing system, which is a self-contained unit that consists of both the battery, the circuitry, and no longer a lead, but the electrode all in one unit. It's implanted via the femoral vein into the right ventricle, and these tines or fixed screw are used to affix the device to the ventricle. The first leadless pacemaker to enter the market was Nanostim in October 2013. The first device to receive FDA approval occurred about a year ago in April 2016 and was the Medtronic Micra transcatheter pacing system. At present, it is the only available device for transcatheter pacing. And just last month, CMS approved reimbursement coverage for Micra when used in accordance with FDA-approved labeling for the device. The approved indications include symptomatic paroxysmal or permanent high-grade AV block in the presence of atrial fibrillation, as well as symptomatic paroxysmal or permanent high-grade AV block in the absence of atrial fibrillation as an alternative to dual-chamber pacing when the placement of an atrial lead is considered to be high risk or difficult or not necessary for effective therapy. Similarly, it is indicated for symptomatic sinus node dysfunction as an alternative to either atrial or dual chamber pacing when the same caveats regarding atrial lead placement. The advantages of a transcatheter pacing system is the potential to avoid complications of traditional pacemaker therapy, including local pocket infections, erosion of the device to the skin, lead dislodgement, and fracture of the lead. It at present is contraindicated in patients with an implanted IVC filter who do not have the ability, femoral venous anatomy, to accommodate a large 23 French introducer sheath, that have a mechanical tricuspid valve, have another device that might interfere with sensing of the transcatheter pacing system, and have extreme obesity where the distance between the device and the chest wall is such that you would not be able to communicate with the device to reprogram it. There is a requisite for heparin administration during the implantation, so patients cannot be intolerant to heparin. And MRI scans may be contraindication for some patients with transcatheter pacing systems. So how do I tell what kind of device a patient has when I'm presented with them? In terms of looking at, well, is this a Medtronic device, a Boston Scientific device, St. Jude device, who manufactured this device? There is a radiographic label on all devices, and so if the patient's had a chest x-ray of sufficient quality that you can magnify and identify a 3-digit code, you are able to look this up online and identify whose device it is. As to the type of device, we talked about the difference in size of the generator or can between pacemakers and defibrillators. looking for the presence of high voltage leads with defibrillation coils to identify a defibrillator, and looking for a coronary sinus or epicardial lead to identify a resynchronization device. There is contact information for all of the major companies, and they willingly accept phone calls from providers to help identify if the patient before you is one of their patients. So some important topics related to managing devices, particularly in an emergency or ICU setting or in specific conditions that might present themselves for inpatient care. Magnet application. If you place a magnet, a cardiac magnet, on a device, you will get a different response depending upon the type of device that it is. So if you place a magnet, on a pacemaker, it will result in an asynchronous mode of pacing. So it will result in, if the device is programmed DDD, it will result in DOO pacing, meaning that it will pace the ventricle without the atrium and the ventricle, without sensing either the atrium or the ventricle, and without responding to a sensed event in either case. So it's just going to fire both the atrium and the ventricle at a predetermined rate, regardless of what the underlying rhythm is doing. If you place a magnet over a defibrillator, you are going to turn off tachyarrhythmia detections. That means that the device will not treat any tachyarrhythmias because it won't see them, it won't detect them. It has no effect on pacing, so it won't put them into an asynchronous mode of pacing. There are some concerns with some devices, really, that there are probably very few left active in patients that had some issues. When you took the magnet off, they would not revert out of magnet mode. But placing a magnet on a device is a very reasonable method of managing a patient who presents for an elective surgery or who presents with a lead malfunction. This is a way to manage these patients before someone with a programmer can come and reprogram the device. So some points about device troubleshooting. There are a number of pacemaker malfunctions that can occur. When I say pacemaker, obviously it's not only the device that's a pacemaker, but defibrillators with pacemaker function or with resynchronization devices that have pacemaker function as well. So there can be a device that fails to pace, meaning you don't see pacemaker stimuli, or fails to pace with pacemaker stimuli, or that you get under inappropriate pacing, and we're going to go through these a little bit. So oversensing. So just to review, sensitivity is what the device sees. We program it to a certain value so that it only sees events above that fence. If the fence is lowered, it's going to start to see lots of events, which could complicate how the device works. So here is a device that has an atrial lead manifest by this top line, a ventricular lead with near field electrogram represented here, and a far field ventricular electrogram. And what we see are a lot of very high frequency noise, basically, where there's just events that could not be physiologic in nature because the intervals are too short, and they're all over the place. They're in the atrial lead and in the ventricular lead, and this is oversensing. So the device is oversensing something, whether it's oversensing diaphragmatic depolarization, or if there's a lead problem that it's resulting in oversensing, and it's sensing multiple signals. So it's sensing things that are not just true cardiac events. This is a single chamber defibrillator, and you can see that we see the near field R wave on this electrogram, but then we see periods where it's oversensing and it's sensing all different types of events. You can see here, it actually doesn't sense these events. So these events, even though you can see them recorded on the printing of the electrogram, they're below the program sensitivity and are not detected by the device. But here, the amplitude is sufficient that they are detected by the device and labeled as ventricular fibrillation sensed events, but the interval is non-physiologic. A cycle length of 140 or 160 milliseconds is really non-physiologic and represents noise from an external source or from an internal problem, such as a lead fracture, evidenced by this clear break in the lead itself. So what about if the device isn't capturing? So this is a representative ECG with intermittent loss of ventricular capture. And so what we see is we see labeled a sense event, and then we see pacing spikes. And so it's an appropriate atrially sensed event. The timer times out, the device tries to pace because we see evidence of an electrical impulse, but there's no capture of the ventricle. And then we see times where we see a pacing spike, but if we look at this QRS actually looks just like the intrinsic QRS. When we see ventricular capture, which occurs here, we see a wide QRS that looks more consistent with pacing. So why could this happen? Well, it could happen for a number of reasons. There could be a technical or mechanical problem with the hardware itself, such as a dislodged atrial lead, which you can see pointing down towards the valve in this radiograph. Or it could be that there's perforation and that the distal electrode is now outside the not only the endocardium and myocardium, but the epicardium, and can no longer actually capture myocardial tissue. Similarly, though, electrolyte derangements can result in non-capture. Undersensing. Well, undersensing is that the device is not seeing true intrinsic depolarizations that have occurred. So for example, this is an example of atrial undersensing in an AAI pacemaker. So we clearly see that there is a P wave. It's not sensed by the device, however, because the device tries to depolarize the atrium at this point in time. So the pacing is occurring independent of any intrinsic sensed events. Another example would be where we have a lower amplitude where for some reason the device is just not sensing the intrinsic atrial activation, and so therefore is trying to pace. So the amplitude of the event is rather small, as you can see here, but it's sufficiently large that it's detected. It's above the fence of sensitivity, so the device sees it. Here there's a reduction in the amplitude of the event, so the device no longer senses the event, and therefore when the timer times out, it sends a depolarization signal to the atrium. This is something that can often be seen in atrial arrhythmias. Devices may have difficulty sensing atrial fibrillation because the amplitude of the F waves can be smaller than the normal P wave. Another problem that we see is ineffective defibrillation, and this can occur for a number of reasons. It could occur because of the patient's body habitus, lead position, and or electrolyte abnormalities or antiarrhythmics. And so if it's not a reversible cause, we frequently have to place additional shocking electrodes to try and improve the vector of defibrillation. So for example, a posterior tunneled high voltage lead will help pull the vector more posteriorly to capture more of the myocardium. This is an example of a transvenous high voltage lead placed in the azygous vein, again to drive that vector more posteriorly. People have even placed high voltage leads in the coronary sinus, which is a posterior structure to improve the defibrillation vector. Their antiarrhythmics can have a number of varying effects on defibrillation thresholds. In fact, amiodarone is known to increase the defibrillation threshold level, and it used to be that we routinely tested patients' defibrillation threshold levels on amiodarone. Conversely, sotalol decreases the defibrillation threshold limit and has been used from time to time therapeutically to reduce defibrillation threshold levels in patients who could not have revision of their device system. Inappropriate shocks. Unfortunately, inappropriate shocks still do occur. As mentioned, the device really determines whether an arrhythmia is present or not based primarily on rate. There are discriminators looking at morphology and RR stability, but patients still can receive inappropriate therapies for atrial fibrillation, as shown in this electrogram. The A channel shows that the there's an atrial arrhythmia that's very rapid with some changes in morphology of the intracardiac electrogram, and that the ventricular rate is fast with some variation in cycle length, but unfortunately the patient does receive an inappropriate shock for atrial fibrillation. Inappropriate shocks can also occur for T-wave oversensing, more commonly seen in patients with hypertrophic cardiomyopathy, sometimes during exercise. And this is when the amplitude of the T-wave is dynamic and gets counted as a second event. So there's a V-sensed event with the R-wave and a second V-sensed event with the T-wave. So there's effectively double counting of the intrinsic rate, and can result in therapy such as ATP here, an attempt to terminate what the device perceives to be an arrhythmia. Loss of resynchronization is another issue that can impact patients significantly with worsening of heart failure, admissions, and decline in exercise capacity. So the baseline ECG shown here, again, wide left bundle, sinus rhythm. Following resynchronization, we see a very prominent R wave in V1 with a narrow QRS. There is sort of a QR in lead 1, suggesting that we are pre-exciting the lateral left ventricle. And then we can see that the lead was actually placed in the middle cardiac vein and probably wasn't very basal, but is some more lateral. And here we have the lateral view showing where that lead was. Patient represents with symptoms of worsening heart failure, and their ECG is shown here, and the lead is pulled back, and you see the lead is pulled back all the way actually back up into the atrium, and there's no longer a lead in the coronary sinus. With placement of an epicardial lead, given concerns about stability, we see now, again, very nice pre-excitation of the lateral left ventricle with the prominent R wave in V1, and now we actually have achieved a Q wave in 1 and a tiny RS in L. And there's placement of the epicardial lead in the basal lateral left ventricular wall. Well, why could this happen? Actually, in this case, this patient had something called Twiddler syndrome, where they have this unconscious playing with the device and twisting of the device till they wind up all the leads and pull them back from their positions. Pacemaker-mediated tachycardia is an entity that can be observed, more often treated with device algorithms, but what happens is that there is a premature ventricular contraction with retrograde conduction to the atrium that is sensed by the device, thought to be sinus in origin, paces the ventricle, and then this cycle of a reentry circuit occurs. And it can be overcome by adjusting some programming parameters in the device. Typically, the classic finding is that it's a paced rhythm at the programmed upper rate limit of the device. And again, there are a number of algorithms that can terminate the arrhythmia by progressively lengthening this postventricular atrial refractory period such that that retrograde activation is no longer seen. Infection. Device therapy is increasing, and as a result, we're seeing an increase in complications. Can be manifest. One manifestation could be device infection, as evidenced by local infection with swelling and redness of the pocket. Sometimes we see overt erosion, clearly infected by definition, as the hardware is now outside of the body, or with endocarditis manifest by vegetations, and represent a clear indication for removal of not only the generator but the leads themselves. And we've seen a lot more complications as we are utilizing devices. We've talked about erosion and local infection. Sometimes we see occlusion in patients who need upgrade of their system, or device malfunction with a subclavian crush where the lead is compressed under the clavicle and develops loss of insulation and malfunction. When we have to remove leads and hardware, we really must individualize what's the risk of lead abandonment versus the risk of extraction. And this is done on a case-by-case basis, taking into account what we think the potential risk of abandonment is, as well as the risk of extraction. Most recent multi-center study looking at rates of major adverse events and mortality have a rate of about 1.5% for major adverse events and a 0.3% mortality rate. Okay, moving on to questions. So a 68-year-old female with a dual chamber ICD is scheduled to undergo elective hemicolectomy. Recent device interrogation reveals no underlying rhythm with 100% atrial and ventricular pacing. Which of the following interventions will be most appropriate or most likely to prevent inappropriate inhibition of pacing by surgical electrocautery? And the answer is to reprogram the defibrillator really to an asynchronous mode. So if you, first and foremost, I guess, is electrocautery really does need to be close to the device to inhibit pacing. That being said, probably in someone who's completely dependent on their device with no underlying rhythm, it's safest to reprogram the device than to say, oh, well, we're working in the abdomen, which is pretty far away from the pectoral device, and probably she'll be okay. If you were to place a magnet over the ICD, it will simply turn off detections, but it will not revert to an asynchronous mode of pacing. In order to do that, you must reprogram the device to an asynchronous mode of pacing. It's simply the safest way to prevent inappropriate inhibition. All right. Question 2, a 35-year-old male lumberjack with cardiac sarcoid and dual chamber ICD presents with new onset lightheadedness and near syncope, and the following rhythm strip is obtained. Which of the following explains his symptoms and ECG findings? Well, if we go back and look at the surface electrocardiogram and now what is shown on interrogation of his device, it might help us answer this question a little bit better. And so we see that there's atrial pacing followed by ventricular pacing. We see this because there's a spike followed by a P wave, and then a spike followed by a wide QRS. Then we see atrial pacing, again with atrial capture, but we don't see a spike this time, nor do we see evidence of ventricular capture. And then we sort of see a similar pattern here again. And so what we're seeing is there's actually loss of ventricular pacing. And so it's not that it's not capturing, because if it were a failure of capture, we'd expect to see a spike, but just no capture of the myocardium. But we don't even see a spike. So the device is saying, I see something, so I don't have to deliver an impulse. And if we look at the intracardiacs, they're going to help us understand what exactly it's seeing. And so what we see is that there is, again, this is the near field channel in the A. Actually, this is a surface lead QRS. This is the near field channel in the A, and this is the near field channel in the V. You'll see that there is an atrial paced event, this AP, with a near field electrogram representing that the atrium depolarized successfully. And then this, however, is interpreted on the ventricular channel by the device as a V-sensed event. And then the true ventricular event, intrinsic ventricular conduction, is detected as a VF event because it's a second ventricular event on the V channel in short order. And so we see this again. There's an atrial paced event. This time it is not detected on the device, but there's a ventricular paced event, and we start seeing that there's oversensing that occurs when it senses a V-sense event. It's inhibiting. So this actually represents loss of ventricular capture due to ventricular oversensing. It could be a result of something as a lead fracture where there's make-break connections that occur. So at times you're seeing no evidence of lead dysfunction, but at times you're seeing oversensing of multiple signals. What is the best pacemaker mode for temporary pacing in a patient with third-degree AV block and a ventricular escape rate of 30 beats per minute following mitral valve surgery? So DDD pacing really allows for a patient with complete heart block to benefit from AV synchrony. And in a patient following mitral valve surgery, optimizing hemodynamics really would be the best option.